Welcome everyone, and thank you for joining us for the next webinar in the Emergency Preparedness Network's 2021 COVID-19 webinar series. This time we're focusing on the vaccine. And today we're going to talk about the impact of the COVID vaccines on infection prevention and control in home care. And we're lucky to have Heather Saunders, an infection preventionist, here to discuss these issues with us today. Before we jump into the presentation, I'd like to thank Shar McCready and Sarah Nagy behind the scenes for all the work they're doing. You can't see them, but they are making things happen to support the webinar series. And of course, as always, I'd like to thank the Maryland Emergency Preparedness Network team, the Office of Preparedness and Response at the Maryland Department of Health, who is responsible for funding this series and is the brainchild behind it. MINCA is the lead for implementing the series, the Maryland National Capital Home Care Association. And if you are interested in learning more about Maryland's premier trade association for home care, you can go to minca.org, mncha.org, or contact Dawn Seek, dseek@minca.org to learn more. If you'd like to learn more about the Emergency Preparedness Network, you can go ahead to our website at mdemergencyprepnetwork.org. And if you'd like to learn more about me, I'm Dr. Charlene Brown, the CEO and founder of Learn Care Together, and we're partnering with MINCA to bring you this webinar series. You can reach me at hello@learncaretogether.com. So we have a number of upcoming workshops that we're excited to invite you to attend. On June 17th, Dr. Jody French will be talking about the mental health needs of older adults who are living independently and how you can support their in-home caregivers during COVID. And then we have 3 workshops. It's essentially the same workshop opportunity repeated 3 times on how to increase caregiver vaccine confidence. June 9th from 9 to noon, June 15th and 16th from 4 to 5:30 p.m., and June 23rd and 24th from 11 a.m. to 12:30 p.m. So the workshop itself is 3 hours, and you have 3 opportunities to participate for those of you who are still working with your caregivers to increase their engagement and excitement around the COVID vaccines. You can sign up for either of these workshops at mdemergencyprepnetwork.org under the events tab. Now, I'm very pleased to introduce Ms. Heather Saunders, who is the consultant, and she's the Director of Infection Control for the Office of Population Health at Johns Hopkins Hospital. Heather is an experienced and motivated RN who has an MPH and certification in infection control. She is a visionary, she is an innovator, and she uses strategic leadership methods to achieve program goals. And she did this when she was working as the lead for infection prevention and control for the state of Maryland during and throughout the COVID pandemic. She guided the state's IPC efforts for the government, and in that role has her finger on the pulse of what's been going on with COVID and COVID vaccines on a state level. She also worked at Johns Hopkins Hospital as an infection control epidemiologist before moving on to the state, and is the founder and primary consultant of Broad Street Prevention, which is a consultancy that guides healthcare and business leaders in the infection prevention and control. And this will be the time if you or your business need help with infection prevention and control, given the global pandemic that we're in, just reach out to Heather at Broad Street Prevention. So now I'd like to hand it over to Heather to take us on this journey through infection prevention and control post-COVID vaccine in Maryland. Take it away, Heather.
Thank you so much, Charlene. I'm so pleased to be here today. Can you see the screen okay?
Yes, we can. It looks great.
Excellent. Well, like I said, I just really have been looking forward to the conversation that we get to have today and the discussion around 2 of my favorite subjects. Number one, how do we prevent and control infections in multiple different environments? But of course, today we're talking specifically about home care, and then also the COVID vaccines, the new tool that we have in our tool belt to prevent and control the spread of COVID-19. I'm really looking forward to discussing how COVID vaccines are impacting the prevention and control of infections in home care. And so just to dive right into our conversation, our discussion today, just want to start really quickly with a brief disclosure slide. for any of the potential financial conflicts of interest that I have, although in the context of the subject of this presentation, there are none, but you can see those disclosures here on that slide. So for objectives, let's talk about what do I hope to accomplish through today's presentation. I really want to impart to you some knowledge that you're going to be able to use on the front line of preventing and controlling infections in home care. And to do that, I first want to talk about the core strategies for preventing and controlling infections in home care. What strategies have not changed during the COVID pandemic? These are the strategies that have been and always will be universal truths in preventing and controlling infections. Secondly, I want to discuss with you all what new infection prevention and control strategies we've adopted into home care during the COVID pandemic. These are those strategies that over the past year were new strategies that we used to make sure that we were keeping ourselves and our clients safe from COVID-19. And then finally, and most importantly today, I want to talk about those strategies that we implemented over the past year. Which one are we going to keep? Which ones are we going to adapt? And which ones will we eventually or now go ahead and discontinue? So let's go ahead and dive in and start with those strategies that haven't changed. We're going to talk about those universal strategies that we all use to prevent and control infections, not just COVID-19, but all infections in home care. So like I said, so much has changed over the past year. COVID has brought a wealth of change to the workplace, to our personal lives. But in the prevention and control of infections, there are certain strategies that remain universally effective. Several strategies that I want to talk about today include standard precautions, the precautions that we take when caring for all clients, no matter their infectious status. Also talking about transmission-based precautions, and those are those strategies that we use whenever we know or suspect somebody to have a specific infectious disease. And then also isolation and quarantine. A lot of people are surprised to hear that these are not new strategies. They're universally effective strategies that we've used to prevent and control infections throughout the course of history. So in standard precautions, those strategies that we use for the care of all of our clients, we have hand hygiene, environmental cleaning, the use of personal protective equipment, sharp safety, safe linen handling, and respiratory etiquette. Those are strategies that we use regardless of who we're caring for and what their infectious status is. Now, transmission-based precautions are a little different. These are the strategies that we use whenever we know someone to have an infectious disease. We still use standard precautions, but we use specific precautions to prevent and control that disease. We do this with COVID-19, and those are some of the strategies that we've adapted and developed over the past year. We also use isolation and quarantine. As I mentioned, this is not a new strategy. We've isolated and quarantined individuals in the past throughout history, including for things like measles, polio, smallpox, and tuberculosis. So now we're using this also with COVID-19, but these are strategies that haven't changed. They've always remained and they always will remain even after the COVID pandemic. So I'm not going to get too much in depth into these strategies today, but because this is my heart as an infection preventionist, I did want to give you a little bit of an in-depth review that you can go through after the presentation. So included in this slide deck that you'll be able to review at the end of the presentation are some additional slides that go into each of these universally effective strategies. So you can make sure that you are adopting and implementing them correctly in your own practice. I did, however, want to make a note of some of the common gaps that we see in some of these universal effective strategies. And these gaps are commonly seen throughout really the healthcare industry, but also in home care. And those would include missed hand hygiene opportunities, missed cleaning and disinfection opportunities, missed opportunities for personal protective equipment, or incorrect use of personal protective equipment. So with hand hygiene, we know that there are specific times that we should wash our hands, both just in the general community, such as after using the restroom and before eating, but also within the care that we provide to our clients, such as before contact with a client or after contact with a client. And what we often observe is that there are certain times where those opportunities are missed, and missed opportunities can sometimes lead to the transmission of infectious diseases. We also see missed opportunities for cleaning and disinfection. So cleaning and disinfection could be specific to the environment, the client's environment, but it also includes specific equipment that we use, maybe such as our stethoscope or our phone, which a lot of people forget can be a vector of infection. We also see some missed opportunities, like I said, for the use of personal protective equipment, maybe such as gloves that we use sometimes for standard precautions when we are anticipating contact with blood or bodily fluids. Maybe that is for an IM injection. Maybe it's for performing a blood glucose test. Sometimes we see that miss in the use of personal protective equipment. We also see incorrect use of personal protective equipment. And this is when it's applied incorrectly or removed incorrectly, but there's a number of different opportunities where we see the incorrect use. So these are some common gaps. And the reason that I want to share this with you today is, these common gaps can also lead to the transmission of infection. So we want to make sure that we address those common gaps so that we are really good at preventing and controlling not just COVID-19, but any infectious disease. Let's go ahead and move on to those strategies that we implemented over the past year that were specific to preventing and controlling the spread of COVID-19 in home care. And these were strategies that we learned about and that changed and we adapted or modified over the course of the last year, because if you remember, this was such a rapidly changing situation and we were learning so much about COVID-19 that we were really kept on our toes with the guidance as the guidance changed and evolved over time. But there are some core strategies that we implemented over the last year that, despite those that persisted throughout the pandemic that we had known of before, like the ones that we just discussed, hand hygiene and cleaning, there were some strategies that were new to us that we adopted and implemented over the last year so that we could be really, really good at preventing and controlling COVID-19 and home care. And those strategies include things like routine asymptomatic testing for COVID-19, physical distancing, or what was also known as social distancing, and the universal use of certain types of PPE. Routine screening and monitoring, screening meaning the entry screening or the before work screening we did so that we could quickly identify specific infectious diseases. Improved ventilation and air quality, another really important piece of preventing and controlling COVID-19. And then of course, COVID vaccines. And we're going to get into talking about each of these in a little bit of detail. And then a little later on, we'll talk about how each of them have changed or have not changed in light of vaccines. So I do want to make a really quick note, and that is that I really love cheese, especially Swiss cheese. No, I'm just kidding. But I really love this model about Swiss cheese. This is actually from an article from the New York Times. And it was talking about how good prevention and control, specific to COVID-19, is a lot like Swiss cheese. And if you've ever heard of the Swiss cheese model, when you're looking at a block of Swiss cheese, of course, Swiss cheese has a lot of holes. Sometimes those holes line up, but eventually, if you have a large enough block of Swiss cheese, you're not going to be able to get all the way through that block by those holes lining up. And prevention and control is often the same way. We want to use a multi-layered strategy for preventing and controlling infections because no single strategy is effective at preventing and controlling COVID-19. So we don't just use social distancing and throw all the other strategies out of the book. We use social distancing, we use masking, we use vaccines, we use ventilation and air quality. All of these different strategies lined up together help us to prevent infection from going from one individual all the way through those strategies to another individual. It is how we are most effective at preventing and controlling infections. So I want you to keep that in mind as we go through each of these strategies, that no strategy should we focus solely on because it's all the strategies all together that really make our prevention and control airtight. Let's also talk for a moment about COVID-19. How is COVID-19 transmitted? How does it get from one person to another? The reason I want to talk about this is I think it is so important for us to understand how it's transmitted so that we can understand how these strategies are helping us to prevent the transmission or the spread of COVID-19. So I'm going to talk about three what we call modes of transmission, ways in which COVID-19 spread. So first is droplet transmission. And when we talk about droplet transmission, what we're referring to is the person-to-person transmission that occurs via larger droplets that are expelled from an individual. And those larger droplets, because they are larger, they can only travel a certain distance before they typically will fall and land on a surface, potentially contaminating that surface. At that time in which they're expelled from that individual, they can be inhaled by another individual, or they can even potentially land in their mouth, their eyes, or their nose, or an individual can touch one of those surfaces that have been recently contaminated and then infect themselves by touching their eyes, their nose, or their mouth. So those droplets typically will travel up to around 6 feet or so, is what so far science has been able to show us. But again, those are larger droplets and they're only going to travel so far before they fall and land to the surface. Now, we also know that COVID-19 can be transmitted by what is called aerosol or airborne transmission. So aerosol transmission is a little different. The person is still expelling the virus, but it is being expelled in finer, more tiny viral particles, and those remain suspended sometimes in the air, and they can be inhaled by another individual. And this is particularly an issue in poorly ventilated settings or crowded settings where we have more potential for being in contact with those viral particles suspended in the air. We also know that certain medical procedures can be a higher risk for aerosolizing these tiny viral particles of infection. So things such as nebulizer treatments, for example, are medical procedures that can produce these fine aerosols. And when someone is infected with COVID-19, those fine aerosols can then be inhaled by someone else. So contact transmission, that is another mode of transmission for COVID-19. And during the start of the pandemic, it was thought to be one of the more common modes of transmissions, right in line with droplet or aerosol transmission. However, over time, we found that contact transmission is a much lesser mode of transmission for COVID-19, although it's still possible that COVID-19 can be transmitted by contact. But what we mean by contact transmission is just that. We are contacting with our hands the virus, likely on contaminated surfaces, and inoculating ourselves or infecting ourselves via our eyes, nose, mouth. So those are the modes of transmission for COVID-19. Again, really important to understand so we can understand how these strategies impact the halting of the spread of COVID-19, the stopping transmission. All right, so let's dive into these strategies, and let's start first with that universal use of personal protective equipment. If you remember back to March, April, May, during this time period last year, everyone started to mask up. Masks were seen being worn in the grocery stores, in common areas, even in the parks, and of course, in healthcare settings, including home healthcare settings. We adopted a strategy of universally masking and applying universal eye protection. And we did that for a couple of different reasons. Let's talk first about universal masking. So that was recommended that at all times it would be worn while providing care for healthcare settings, including home healthcare. And then it would be worn at all times within healthcare facilities. And the masks serve two purposes. And I think it's really important to understand this. The mask serves two purposes. Number one, those masks protected other individuals from my potentially infectious droplets, the wearer's potentially infectious droplets. So it provided what we call source control. Second reason is it protected the wearer from the potentially infectious droplets of others. And when everybody was masking, we were protecting one another. Universal eye protection, however, the use of goggles or a face shield, that was recommended by CDC during times of moderate to substantial transmission, particularly for healthcare settings. And so in home healthcare, we used eye protection to protect ourselves. We protect the wearer from exposure to potentially infectious droplets, because we know that the eyes are a potential area in which we can expose ourselves to respiratory droplets or aerosols, and we want to protect those eyes by wearing really good eye protection. So it protected us, protected the wearer. Let's talk about physical distancing, another strategy that we implemented in the last year. We have these signs and symbols all over sidewalks and in buildings that say social distancing, stay 6 feet. Now, where did that come from? If you remember the 6 feet, we talked about that in droplet transmission. Respiratory droplets have been known to travel up to 6 feet. So by staying 6 feet away, we were trying to reduce the risk of droplet transmission, person-to-person droplet transmission. So we called that physical distancing, we called it social distancing, and we recommended it at all times when we were outside one's immediate household. When we were in an area with other people, we would try to stay 6 feet, social distancing. And again, that was just to reduce the droplet transmission, still wearing masks, but staying 6 feet. Again, another layer of cheese. We're just stacking layers here by using physical distancing and universal masking. What we also did in the past year, and this is particularly for healthcare settings, but others, as you'll see, is we implemented the use of routine asymptomatic testing. Asymptomatic because we learned quickly that COVID-19 can be transmitted from individuals that had asymptomatic infection. They were showing no signs or symptoms of COVID-19. However, they could still transmit it to other individuals. This necessitated that we test people routinely at a varying frequency so that we could quickly identify infection. That is the goal when you're containing any infectious disease, is you quickly identify and isolate the infected person. So to contain the infection, we had to do the routine testing. So we did this in a number of different settings, including home health care for home health care staff, long-term care facilities, even new admissions to the hospitals. Businesses started to implement this strategy. Amazon had their own testing laboratory just to do routine testing for their employees. Schools even started to implement routine testing for children and teachers. Like I said, the testing and the strategy, that can vary, but routine testing became an integral part of preventing and controlling COVID-19 in the community. Another integral strategy, and I know everybody recognizes those thermometers, those touchless thermometers, because everybody was doing routine screening and monitoring. We did routine screening at the entry of buildings or at the entry of facilities, and we did routine before work screening for our employees. So our home healthcare staff were required to fill out a checklist that verified that they didn't have any signs or symptoms of COVID-19. Some people had it on their phones. Some people had to complete it on a computer. Some people had to text their boss and say, no symptoms today. One way or another, we were verifying that we didn't have symptoms before we started our shift. Entry screening, before work screening, there was multiple different ways that those strategies were completed. But we were making sure that we were infection-free if we were going to go care for our clients. We were also monitoring our clients for infection routinely. Every visit, we were making sure they were not showing any signs or symptoms of infection. So there were multiple strategies, like I said, including the temperature screening, symptom screening, the physical assessments, but this was a very integral strategy for the course of the last year. As I mentioned, COVID-19 has multiple modes of transmission, including airborne and aerosol transmission. And we learned this later on in the pandemic, how much of a role that this potentially played in the transmission of COVID-19. And so ventilation and improved air quality became a really important strategy, another layer of cheese to prevent and control the spread of COVID-19. As I mentioned, poorly ventilated spaces really can contribute to the increased viral particles, those small viral particles that can potentially be inhaled by someone else. So if we improve ventilation, if we improve air quality, then we can potentially reduce those viral particles. So that's the goal here. There's a number of different ways that we can do this, but some options for doing this in a home care setting, and particularly in residential settings, include opening up those windows and those doors, get the natural air in, circulate that natural air. So this is natural ventilation. It's a great way to improve ventilation and air quality in a residential setting. You can even use window fans, and you point the window fans to the outside, so you're exhausting the air to the outside. You can utilize exhaust fans in the kitchens, in the bathrooms, keep those going at all times too, so you can exhaust that air up to the attic and to the outside. You can also consider HEPA filters. So HEPA filters are commercial filters that we use in the home and in businesses to circulate and filter out the air, improve the air. So it's an air filter. You could consider doing this at all times. You could consider doing it for your clients that have COVID-19. But this is another consideration offered for improving ventilation and air quality. So although this isn't an option for improving ventilation and air quality, I think this is a good time to also mention that your home healthcare staff that are providing care to clients with COVID-19 suspected or confirmed, they should be also planning for the potential for airborne or aerosol transmission by making sure that they have a respirator that they can use, such as a fit tested N95 or another type of respirator. There's elastomeric, there's PAPRs, lots of different types, but we want to make sure that they're fit tested and protecting themselves from potential airborne or aerosol transmission when there is a suspected or confirmed case. So another option for for improved ventilation and air quality is to get outdoors. If it is safe to do so, if it is appropriate to do so, and there's a private space for that visit and the care is appropriate, have that take place outdoors, maybe in the backyard, on a patio, whatever that may be. If it's just a quick check-in, suggest doing that outdoors. And COVID vaccines. So arguably the best method for preventing and controlling infections. COVID vaccines have given us an opportunity to completely interrupt the spread of COVID-19, not just at an individual level where a lot of these strategies work, but at a population level. That's what's so important to understand about these vaccines, is it's significantly reducing the spread of COVID-19 at a population level. So we have multiple different kinds of vaccines that are available. One study that has come out recently shows that mRNA vaccines, that would be the Pfizer and Moderna vaccines, are 94% effective in preventing symptomatic COVID-19 illness. That study is linked there, but it was specific to healthcare workers in multiple different kinds of settings, including our frontline healthcare workers, our EMS, even frontline individuals not in the healthcare industry. So kind of a mixed bag of different types of individuals, but great study that shows high levels of effectiveness in preventing symptomatic COVID-19. And the J&J, or the Janssen vaccine, has been shown to be 66.3% effective in clinical trials at preventing laboratory confirmed COVID-19. And that was in people that had no evidence of prior infection 2 weeks after receiving the vaccine. So we have some highly effective vaccines that help to give us that opportunity, again, to interrupt transmission at that population level, the more people we get to receive that vaccination. And because of those vaccines, things are changing, right? There's so much new guidance. The regulations are changing, and it makes things a little confusing trying to figure out how to navigate this next phase, the post-vaccine phase. And what then does infection prevention and control in home care look like? What strategies do we change? Which ones do we keep? Which ones do we modify? It's a really confusing landscape right now. Completely understand it to be so. And I want to walk you through today some of those strategies we just talked about. How are they changing after vaccination? How are we navigating those changes in policies and procedures so we can start to walk together through those next steps in this next phase? All right, so before I do, I want to talk about guidance. What guidance do we use? There's a lot of guidance out there, and I want to set the stage for what guidance I am using to talk you through the next part of this presentation. So CDC's infection control guidance for healthcare settings actually includes home healthcare. And I think a lot of people miss this. And so I wanted to point this out because this is the guidance that I'm going to be using and I'm going to be pointing and directing you to. So CDC specifically actually defines healthcare settings. They state that healthcare settings includes places where healthcare is delivered. And that includes, but is not limited to, and then they list all the different settings that they are applying their guidance to. And that includes, as I bolded here, home health care. So the home health care setting is included in CDC's infection control guidance for COVID-19. That includes the updated guidance that they provided for infection prevention and control post-COVID vaccine. Also includes the large bulk of infection control guidance on IPC during the COVID-19 pandemic. So if you have not taken a look at those guidance documents yet, I linked both of them here and would highly suggest that you walk through these, because although I'm going to try and talk about some of this guidance that has changed or that we're modifying, or maybe that we're going to keep, I want you to be aware of that guidance and know where to find it and be able to stay up with the new and changing guidance. I'm sure we're going to hear some more things as things progress. All right, so let's talk about the strategies that we're going to discuss. So the ones that we discussed previously, we're going to include those in this next stage of our discussion, such as the universal use of personal protective equipment, physical or social distancing, routine testing, screening and monitoring. And then we're also going to talk about quarantine and isolation. You'll remember I talked about that in the beginning, but there's some changes there, so it's important to understand. And then caring for individuals with COVID-19. We want to run through that as well. All right, just a note about post-vaccine recommendations, infection prevention and control recommendations. So per CDC, as everybody may be aware, in light of all the recent data, they have released guidance that vaccinated individuals, those that have been fully vaccinated 2 weeks post-vaccine, they are now able to safely resume pre-pandemic activities without masks and social distancing. So the caveat here is that is while in the community. Businesses are going to make their own guidelines, they're going to make their own rules, and healthcare settings have a different set of guidance. Like I mentioned just previously in the slide before this one, we are going to refer to the healthcare guidance. And so that is going to be different than the community guidance, but did want to point out that that community guidance is different. What we're talking about today is just specific to our setting, working in home healthcare. I also wanted to mention that fully vaccinated individuals that are immunocompromised, they should also refer to different guidance. So CDC states that they should continue to follow all prevention measures such as masks and social distancing, or they should consider to do so even if they're fully vaccinated, just because at this time we don't know how the vaccine is impacting immunocompromised persons. And so we should be a little bit more careful if we ourselves are an immunocompromised person, or maybe if we live with or care for someone that is immunocompromised. So that's important to keep in mind too as we go along. All right, so let's talk about these masks. So we talked about universal PPE use. We talked about universal masking. And as I mentioned, the healthcare recommendations are evolving. And so pay attention to the interim healthcare recommendations post-COVID-19 vaccine. But right now, at least currently in the guidance, what is recommended is that all vaccinated home healthcare staff do continue to mask while providing care. So essentially nothing has changed there. While providing care, we should continue to universally mask, both for that source control and that protection that that masks offer us. Now, occasionally we also have other people that are in the home. Maybe it is a client's family member, maybe it is visitors, and then the client themselves. So CDC recommends that the safest approach at this time in all healthcare settings, including home healthcare, is for clients and others in the home to continue wearing their source control as well while care is being provided. So during care settings, the safest approach, the best approach, is for everyone to wear their source control, to use universal masking. Now, when caregivers are not present, when there is not healthcare taking place inside the home, then vaccinated clients do have the option of not masking when their vaccinated visitors are present. And of course, when those in the home, those that live within the home would not need to universally mask either. So that's something that you can counsel your clients on, because that community guidance does apply when caregiving is not taking place in the home. And then all unvaccinated individuals, they of course should continue to mask. They should continue to physically distance when around others from outside the home until they're able to be vaccinated. Okay, so do we distance? Do we continue to distance? What does social distancing or physical distancing look like in the post-vaccine um, world? So in healthcare, the recommendations, again, they're constantly evolving as the data is available. But right now, the recommendation is that to the extent possible, home healthcare staff should continue to physically distance from any other occupants or visitors during the care that they're providing to their clients. Of course, the care that we're providing to our clients can't always be physically distanced. That's not reasonable or realistic, but others in the home can physically distance from caregivers or healthcare workers, home healthcare workers. And that's generally the safest approach, is for everybody to maintain that physical distancing when care is being provided. Of course, again, outside of the caregiving situation, when caregivers are not present within the home, vaccinated visitors and clients, they can choose not to physically distance as they can choose not to mask, which is the community recommendations or the community guidance. Once again, unvaccinated visitors, however, they should continue all physical distancing until vaccinated. And this, again, if you want to link to the bottom, comes from the recent healthcare infection prevention and control recommendations that are in response to those COVID vaccines. All right, let's talk about who should be tested. So this routine asymptomatic testing, this is an area where there is a change. So the last two that we talked about, universal masking and social distancing, there's really not much changes there. The healthcare recommendations are much the same, that we should continue masking, we should continue physical distancing where possible. But with routine testing, there are some changes. So we should continue this for the unvaccinated home healthcare workers, but we can discontinue routine asymptomatic testing for vaccinated, fully vaccinated home healthcare workers. So whereas before everyone was getting routine asymptomatic testing, now we can prioritize that to just the unvaccinated home healthcare workers. Again, frequency can vary, and it depends upon the epidemiology of COVID-19 in the specific region where you're at. Is there low levels of transmission where you may be able to increase frequency between testing? Or are there higher levels of transmission and we need to make sure we have more frequent testing? Or potentially there is a higher risk situation or caregiving situation where we feel more comfortable having a higher degree or frequency of testing. So that may vary depending upon, like I said, the epidemiology, the setting, the patient population, and it does vary and has varied over the past year from a week to every 3 days to once a month. So it's going to depend upon your specific situation. Once again, the strategy, PCR is gold standard. So those PCR tests are really the best of the best that we have for testing for COVID-19. But rapid tests of varying types can also be used as a part of your asymptomatic testing strategy. And I would refer to the CDC guidance on routine testing to determine what your strategy and approach should be. So that is for asymptomatic testing, but I also wanted to make a note that everyone that is symptomatic, presenting with any signs or symptoms of COVID-19 should still be tested for COVID-19 immediately and removed from any work situation. So really important to understand, vaccinated or unvaccinated, we still test if there are symptoms or signs. Okay, let's talk about routine screening. So that's that entry screening or that before work screening that we're doing. That is the monitoring of our clients for COVID-19. So, we've found over the past year that this can actually be beneficial for identifying anyone with signs or symptoms of an infectious disease or a change in condition. So that includes our frontline home healthcare workers, screening them for any signs or symptoms. And it includes our clients looking for changes in conditions and any signs or symptoms that they may have that may be pointing to an infectious source. So really the best practice at this time is to go ahead and continue that routine screening. Screen our home healthcare workers upon the start of their shift, look for signs or symptoms of infection, remove and isolate if they have any signs or symptoms and test, and then regularly monitor our clients as we've been doing for any signs or symptoms of infection, change in condition. I did want to make one note though. These asymptomatic touchless temperature monitoring that we've been doing, the screening using temperature it's really been shown to not be as effective. We're not identifying a large number of individuals just from temperature screening. A lot of people present with COVID-19 without fever. And so we miss those that are presenting without fever. We often find them by other signs or symptoms. And so it's really just not been an effective use and tool for screening. So it is something that we can decide if we would like to go ahead and remove, although some people are using that still and keeping that in there. I don't think there's a wrong way to go, and there's not a recommendation to discontinue or to continue, but I think it is helpful to know that they are less useful than they were initially thought to be. All right, so quarantine and isolation. We didn't talk about this in the last section, but I wanted to touch on this because there is a change in the guidance around quarantine and isolation. First, I want to make sure that we understand terminology. Quarantine refers to the isolation of individuals that have been exposed to COVID-19. They are not infected. They are not suspected or confirmed to be infected. They have only been exposed, and they are then isolating themselves for a period of time, monitoring for signs and symptoms due to that exposure. So quarantine equals exposed persons. Now, isolation is what we do for individuals that have been infected with COVID-19. They have a suspected or confirmed infection, and so they are isolating during the time in which they are thought to be infectious. So that's important to keep that terminology straight. Isolation, infection, quarantine, exposure. So fully vaccinated individuals, that's home healthcare staff and clients that have been exposed, those that have been exposed to individuals with COVID-19. They do not need to quarantine due to that exposure any longer. If you are fully vaccinated and you are exposed to someone with COVID-19, you do not need to quarantine any longer due to that exposure. Now, all persons, however, whether they are vaccinated or unvaccinated, if they test positive for COVID-19, then they still have to isolate for the full recommended isolation period that we would have previously for COVID-19. So as a reminder, that is 10 days from the date of the positive test or 10 days from the onset of symptoms. And immunocompromised persons, they may require longer isolation periods. So I would refer to that CDC guidance when making the determination on how long to isolate someone who is positive for COVID-19. So again, just to review, quarantine for fully vaccinated individuals, they no longer have to quarantine for exposure to COVID-19. But those that are positive, all persons that are positive for COVID-19, they still have to isolate for infection for the full recommended period. So there is a little bit of a change there that we do not any longer have to quarantine individuals for exposure when they've been fully vaccinated. All right, let's talk about changes for the care of persons with COVID-19. And actually, there are no changes. So there's no changes to the recommendations for how we care for individuals with COVID-19. It's all the same, whether the client or the healthcare worker is fully vaccinated. When providing care to an individual with COVID-19, we should continue to wear the appropriate PPE. That includes the respirator, so the fit tested N95 or otherwise, eye protection, gown, and gloves. And I want to make a note here that cloth masks are not PPE, so we should not be using cloth masks in any healthcare settings. And especially when caring for someone suspected or confirmed for COVID-19. Generally, home healthcare workers should wear their surgical masks for source control and any other care setting, and then their respirators for when they're providing care to individuals with COVID-19. And then all other previous infection prevention and control recommendations for that care, including placement, isolation, everything else, it is remaining the same regardless of COVID vaccines. One thing that I do want to make a note of is that home healthcare agencies can consider prioritizing now their vaccinated staff for the care of individuals with known COVID-19 infection. So that is something that could be considered now with COVID-19 vaccines out there and being received. So here's the bottom line though, the vaccines are impacting these strategies that we put in place to prevent and control COVID-19 over the past year. And they're impacting and changing those strategies because they are effective. Because at a population level, we're able to use these to interrupt transmission and reduce the spread of COVID-19. And so we've got to improve the uptake of these COVID vaccines, and we can do so in a number of ways. We can address vaccine hesitancy within our staff, our clients, our families. We can educate them about the benefits of those COVID vaccines. We can learn about some of the common vaccine myths, learn about them and become literate and being able to dispel those vaccines and discuss those with people that are concerned about them. And then to the degree that we're able to, we can improve the accessibility and the availability of these vaccines and reduce the barriers to receiving them. So I'm really excited about these upcoming workshops that Charlene discussed at the beginning of this webinar, the upcoming workshop on increasing caregiver uptake, and then the previous webinars on tackling vaccine hesitancy. I think those are really important tools and webinars that we can use to improve the uptake of vaccines in our community. So in summary, we've got to emphasize the core strategies. At all times, those core strategies are effective. So take the time after this presentation to run through the slides at the end of the slide deck so that you can review some of those core strategies. During the pandemic, we implemented a lot of strategies just to aid in the prevention and control of COVID-19, and we reviewed some of those today. But we know that because vaccines are now effective, in some ways, we're starting to change our approach to the prevention and control of COVID-19, which is a great thing. Some things are changing, some things are staying the same, and some things we're having to modify. And so it's important that we continue to closely monitor those developing guidance and regulations so that before modifying any strategies, we can think about the logistics of how do we successfully implement any changes. And then encourage vaccine uptake. That's the bottom line. We've got to get more individuals vaccinated so that we can continue to move forward into more pre-pandemic infection prevention and control strategies. So I just want to thank everybody today for taking the time to be here and listen to this presentation. I hope this has been really helpful, and I look forward to answering any questions that you have.
Bravo. Thank you, Heather. That was a wonderful, wonderful presentation. I loved it. And I'm happy to say we have a few questions. First, so most of the people in our audience work for private duty home care agencies or home health care agencies. And that means they have offices and office staff. So we have a question about whether or not it's necessary to quarantine office staff if they've been exposed after they've been vaccinated.
That is a great question. I'm glad that you brought that up because the guidance for office staff in some places is a little different. So as far as the quarantine of those office staff though, for fully vaccinated office staff, those office staff members that have been vaccinated, they're 2 weeks post-vaccination and they are exposed to somebody with COVID-19. They also do not have to quarantine due to that exposure. So it is the same as it is in the home healthcare setting for those office staff members. Now, there are some differences in the prevention and control of COVID-19 and the office setting because it's not a healthcare setting. So they may and are allowed to go by some of the community guidance, and it is up to the organization and the business to determine how they're going to navigate and implement that. I think one important thing to note is that if we are going to implement any changes, particularly around masks and social distancing, which is what we like to call the primary prevention measures, those are the core prevention measures for COVID-19. If we're going to implement any changes there, we've really got to be able to identify who's vaccinated and who's not vaccinated, and be able to monitor the implementation of any changes in guidance around vaccine status, which is where that community guidance is kind of going. So I'm glad that that question came up because there is a little bit of a difference, but not where it comes to quarantine. Again, fully vaccinated individuals that are exposed to COVID-19 do not have to quarantine. So that's great news.
Actually, this might be a really good time to re-explain the difference between quarantine and isolation. I know you did it before, but in the context of this question, it might be helpful.
Yeah, no, I absolutely agree, because that gets really confusing for a lot of people. And Charlene, I think one of the reasons it gets confusing is we use the term wrong in the media and in Hollywood. We always mix up these terms. So quarantine, again, refers to when we have been exposed to COVID-19. So quarantine is exposed. Those are individuals that are not showing any signs or symptoms of infection, but they have been directly exposed to somebody that have COVID-19. So we want to monitor them really closely. We want to remove them from the population and have them be isolated, but because of that exposure. So quarantine is exposure. Now, isolation is for when we've been infected with COVID-19. We have a suspected or known infection with COVID-19. So we've got to isolate that person for the recommended isolation period because they are infectious. So I think the best way I can ever remember this and recommend somebody to remember it is to remember that infection equals isolation. Eyes, infection, isolation. Isolation is infection. And then you'll remember quarantine means exposure. But really good question. I'm glad you brought that up.
No, that's wonderful. We can thank the audience for such excellent questions. We have another question about whether or not it's important to continue screening staff. So you talked about some of the screening methods that are used. Do agencies need to continue screening staff once they've been vaccinated?
Yeah, that's a really good question. And the recommendation right now is that they do continue screening. That may change. Again, we should really keep a pulse on the guidance and the regulations, but right now, the recommendation is we do continue to screen staff. There are a number of breakthrough infections. The vaccines are not 100% effective. We went through the statistics. And right now, as we monitor the uptake of vaccines and as we monitor these variants that we hear so much about and other developments, we want to make sure that we are identifying also any breakthrough infections that occur. And routine screening is one great way that we can do that. Just a simple form or simple questionnaire that just validates that somebody isn't experiencing any signs or symptoms that we should be concerned about for infection. And this can even be a great way to identify other potential infections moving forward. And there's some talk about, hey, should we just keep this? It's a really simple tool that we can use to make sure that we don't have infectious individuals in our businesses, in our healthcare settings, working and potentially spreading infection. So for right now, the recommendation is continue on with the routine screening.
That's great feedback. Our final question here has to do with testing. So the screening questions and the types of screenings you've discussed are important. To what extent is routine testing necessary for vaccinated staff and unvaccinated staff, including those who have exposure to our clients and those who work in the office?
Yeah, that's a great question. Now, again, going back to the guidance about routine asymptomatic testing, individuals that are fully vaccinated, they no longer need to have routine asymptomatic testing. We're still screening them using that questionnaire, but we no longer need to routinely test them for COVID-19. Our unvaccinated staff members, including our office staff members, really the strategies that we've been using before for routine testing should continue for them. We should continue the routine asymptomatic testing. The frequency and the strategy, again, that's going to vary. It's going to vary depending on a multitude of different things, being the setting in which they work and the clients maybe in which they care for, and then the degree of spread of COVID-19 that we see in the community. So those are things that we're going to keep in mind as we determine those frequency and strategies. But really the unvaccinated staff, that's going to continue. The vaccinated, we can discontinue that.
Thank you, Heather Saunders, for an outstanding presentation. We got some great questions from the audience, so thank you to everyone who submitted questions. And with that, I'm going to, after another round of bravos and congratulations for Heather for an excellent presentation, I'm going to take over your screen and have us just do a few closing comments. So again, we'd like to thank the Maryland Emergency Preparedness Network. That's our network that's putting together this series of webinars on the COVID vaccine. That effort is led by MINCA, the Maryland National Capital Home Care Association. For more information about joining Maryland's premier home care trade association, just reach out at info@minca.org. And then Learn Care Together. Again, we are partnering with MINCA to bring you this webinar series on the COVID vaccine. And of course, without the leadership of the Maryland Department of Health's Office of Preparedness and Response, we wouldn't be able to do any of this. So thank you, OPR. And thank you, audience, for joining us, for the amazing questions that you've asked. And this is just our disclaimer here. And with that, we're going to close out the webinar. But thank you for joining us today. And you have a wonderful, wonderful, wonderful rest of your day. Thank you so much. Bye.